In chemo, there is tumor lysis syndrome, isn't it? High. And calcium will be low. And phosphate is unable to excrete from the kidney. That's why phosphate will be high. Okay, tumor lysis syndrome. Tumor lysis syndrome is a common Tumor lysis syndrome is common in patients with aggressive hematologic malignancy who are initiated on cytotoxic chemotherapy or immunotherapy. Large tumor burden. Some leukemia will have leukocyte count and is a risk LDH is a risk factor. Large scale tumor cell Large scale tumor cell death causes the massive release of the intracellular products into the circulation, which results in potentially life-threatening electrolyte and metabolic abnormality into the following. There may be hyperphosphatemia, hyperkalemia, and hyperuricemia. Tumor cells have up to 3 times more intracellular phosphate than Tumor cells have up to 3 times of more intracellular phosphate than the normal cell. Therefore, massive tumor cell lysis is often associated with hyperphosphatemia. This results in systemic hypocalcemia due to increased calcium phosphate precipitation including in the renal tubule, leading to obstructing calcium phosphate stone that can cause acute kidney injury. Hyperkalemia, because potassium is primarily sequestrated in the intracellular space, massive tumor cell lysis can cause hyperkalemia, which increases the risk of cardiac arrhythmia, and hyperuricemia. Urine nucleic acid released from the lysed tumor cell are metabolized by the xanthine oxidase into the uric acid. Because uric acid is poorly soluble in acidic environment of the renal tubule and collecting system, it precipitates into obstructing uric acid stone, which are another cause of acute kidney injury. Most symptoms of tumor lysis syndrome, uh, that is nausea, vomiting, diarrhea, muscle cramps, seizure, tetany, are also caused by electrolyte abnormality. Tumor lysis syndrome prophylaxis typically includes IV fluid to flush phosphorus and calcium and uric acid out of the kidneys, and the administration of an agent allopurinol, rasburicase, and febuxostat to reduce uric acid level. Yes, I have sent the link of Discord of my. You will see in later. No, you can add my account with that link. You can download it from yourself. You can download it now. Just click the download and it will be downloaded. It is free. It is for finding my account. It is very tough to find an account. Like it is not like what Skype. You will found. You will see that it is very tough to find an account. That's why I have sent the link. There is worsening abdominal pain. Abdominal pain. Ascites. Butt-Chiari, are you thinking about Butt-Chiari syndrome? All the liver enzymes are raised. So, hepatic vein thrombosis. In hepatic vein thrombosis, there may be pain. There is worsening, or in Butt-Chiari, there is pain. Okay. It is not serum alpha fetoprotein. It is not MR cholangio MRCP. Not. It is not this, and not chronic hepatic. It is either A, C, or E. Not a liver biopsy. Liver biopsy is for confirmatory. They want to do the next best step. Either it is abdominal Doppler or diagnostic paracentesis. It is Butt-Chiari. Okay. Even if I know the hepatic vein, I give diagnostic paracentesis. Okay. I need to change my thing like a predetermined conception. It actually makes lots of question wrong. Okay. Butt-Chiari syndrome, hepatic venous outflow obstruction, hepatic venous outflow obstruction usually due to myeloproliferative disorder, usually due to myeloproliferative disorder, malignancy, and OCP. Myeloproliferative disorder like polycythemia vera, malignancy, hepatocellular carcinoma, or oral contraceptive use. Acute, there may be jaundice, hepatic encephalopathy, varicose bleeding, prolonged INR PTT, elevated transaminase. Manifestation subacute or chronic, vague, progressive abdominal pain, hepatomegaly, splenomegaly, ascites, mild or moderate elevation in bilirubin and transaminase. Abdominal Doppler ultrasound will show decreased hepatic vein flow, and investigation of the underlying disorder JAK2 testing for polycythemia vera. This patient's aquagenic pruritus. This patient's aquagenic pruritus, facial plethora, and dramatically elevated hematocrit rise. Strong suspicion for polycythemia vera, a chronic myeloproliferative disorder marked by elevated red blood cell mass. Although polycythemia vera is often discovered incidentally on routine lab, patients may have aquagenic pruritus, in itching worse with water, erythromelalgia, burning in feet or hands, transient vision disturbance from hyperviscosity, or complications related to thrombosis or hemorrhage. The etiology, the etiology of some of these findings is unclear, but improvement in pruritus or erythromelalgia with aspirin may reflect a causative role for prostaglandin, which are pruritogenic. Risk of venous or arterial thrombosis is significantly increased in polycythemia vera due to increased blood viscosity and abnormalities in platelet or leukocyte function. One classic thrombotic complication One classic thrombotic complication is Butt-Chiari syndrome, a disorder marked by hepatic venous outflow obstruction, usually due to hepatic vein thrombosis. Manifestation may be acute, subacute, chronic. Subacute cases often present with progressive abdominal discomfort, ascites, abdominal distension, flank dullness, and hepatosplenomegaly. This may be caused by polycythemia vera directly. Mild or moderate elevation in the liver enzyme bilirubin (ALP) also commonly occur. The diagnosis of the Budd-Chiari syndrome is established with non-invasive imaging such as abdominal Doppler ultrasonography, which typically shows abnormal hepatic blood flow, hepatomegaly, splenomegaly, ascites. Patients with suspected polycythemia vera, as in this case, should undergo blood testing for JAK2 V16 V617F mutation, which is almost always positive. Next. No. Uh, think about crab, bone pain, anemia. Crab is for multiple myeloma. Age above 50, 50 plus, like crab feature, think about multiple myeloma. If crab associated with like hyperviscosity, think about again multiple myeloma related like Waldenström, this and that. And calcium causes constipation. Okay, this patient with constipation, back pain, lab evidence of anemia, renal insufficiency, hypercalcemia, likely has multiple myeloma. Multiple myeloma is a plasma cell neoplasm that commonly presents with manifestation related to bone marrow infiltration, bone pain, fracture, hypercalcemia, anemia, or elevation in serum monoclonal protein, renal insufficiency. At the time of diagnosis, approximately 25% patients with MM have hypercalcemia. Typically, this is a result of osteolytic bone destruction. This is a result of osteolytic bone destruction by the neoplastic plasma cell. May be asymptomatic, Although hypercalcemia may be asymptomatic, with a calcium level less than 12 milligram per deciliter. Fatigue, constipation, and depression are common. This patient's constipation is likely a result of hypercalcemia. Patient with suspected multiple myeloma should have serum or urine protein electrophoresis M spike, a peripheral blood smear willow formation, and serum free light chain analysis. If these screening tests suggest multiple myeloma, diagnosis can be confirmed by bone marrow biopsy. Smoking right leg is swollen and tender up to mid thigh. DVD. Cancer can cause, like, which of the following most appropriate evaluation in this patient's current condition? We can do age-related cancer screening, but because protein C, S, antithrombin, these are like coagulation stuff, and it is very rare. And he is on the way of deathbed, 53. So, so may not be. It should be found earlier, like protein C, S. I think that maybe I think that it is age appropriate. If we do the cancer screening, we can find out the DVT, because cancer age related cancer can cause malignancy, can cause DVT. Pancreatic carcinoma cannot be present with DVT. It can present with depression. It can make you sad, but it can make you other. Okay, you are right. So I am right. I have seen your answer and then I click my answer. Okay. My mind is very fluctuating. So, so that's why I cannot remember the answer, like as it fluctuates. So uh, now I am thinking in that way. The very next day I may not think in other way. Okay, so that's the problem. Okay, so these patients DVT, these patients DVT of the popliteal and femur. This patient has DVT of the popliteal and femoral vein. Risk factor for venous thromboembolism include inherited factor 5 Leiden, prothrombin gene mutation, protein C deficiency, and acquired immobilization, surgery, malignancy, medication factors. Initial evaluation is directed at identifying major cause of venous thromboembolism or factors that can increase the risk of anticoagulation therapy. Evaluation should include careful history. Evaluation should include careful history, physical examination, limited diagnostic testing, blood count, serum chemistry, coagulation studies, fecal occult blood testing, and chest X-ray. In the absence of any clear provoking factors, recent surgery, immobilization, patient with a first episode of venous thromboembolism such as these men should be referred for age-appropriate cancer screening colonoscopy to evaluate for malignancy as a potential risk factor for venous thromboembolism. In addition, any suspicious symptoms of malignancy, that is weight loss, unexplained pain, warrant consideration for more extensive cancer evaluation. CT scan of the abdomen. Okay. After that, like age appropriate cancer screening, after that we can do like CT scan of the abdomen. Okay. For venous thromboembolism. Is there anything you want me to read? Okay. You are so next. Okay, next. Yes, transfusion reaction. Uh, okay, look at he has he got fever after it is febrile hemolytic febrile uh, febrile. Yes, febrile hemolytic. There is febrile non-hemolytic and there is febrile hemolytic. Both of cases there is hemolysis, so you should do direct Coombs test. So if direct Coombs test is negative, then it is not febrile or non-feb like febrile hemolytic. If direct Coombs test is negative, then it is febrile non-hemolytic transfusion reaction, and this is febrile hemolytic, I think so. Okay, so this patient with fever, flank pain, dark urine, 10 minutes of fever, flank pain, dark urine, 10 minutes after transfusion is having an acute hemolytic transfusion reaction, a rare but potentially fatal sorry a rare but potentially fatal transfusion reaction due to transfusion of mismatched blood, ABU incompatibility. The most common etiology is clerical error. Acute hemolytic transfusion reaction typically occurs minutes to hours within minutes to hours of transfusion due to host antibody attacking donor blood antigen. The result is massive blood cell destruction, intravascular hemolysis, which can lead to toxic hemoglobin buildup in the kidney, and renal tubular cell injury and subsequent acute renal failure. Therefore, patients should raise suspicion for acute hemolytic transfusion reaction include flank pain, dark red urine, hemoglobinuria, as well as fever, tachycardia, hypotension due to inflammatory cytokine. Shortly after a transfusion, patient should have elevated LDH and DIC. Diagnosis of acute hemolytic transfusion reaction with a positive Coombs test reflecting antibody-coded red blood cell. Management include cessation of the transfusion, aggressive fluid administration, and supportive care. Okay, next. Yes. Rheumatic fever, vitamin C deficiency, it's none of the answer. C or D. Now pick. Yes. we have missed one serious point here, like gum bleeding, bleeding around the gums. So look, for this patient with severely limited diet has leg pain, severely limited diet has leg pain, petechiae, gingivitis, finding concerning for vitamin C deficit scurvy. This patient condition is rare in resource-rich countries but can occur in patients who are malnourished. Children with autism, as in this case, may have self-restrictive diets that can lack vitamin C rich foods, vegetables, and citrus food, increasing the risk of deficiency. Vitamin C is a cofactor for hydroxylation of proline and lysine, which is essential for collagen cross-linking. Impaired collagen synthesis comprises tensile strength, particularly in the skin and vascular wall, resulting in peripheral hemorrhages, hemorrhagic gingivitis, petechiae, ecchymosis. Intramuscular or subperiosteal hemorrhage can occur, especially in the lower extremity due to gravity dependent hydrostatic pressure with fragile capillaries. This results in pain and difficulty with ambulation, which may be presenting symptoms in children as seen in here. Generalized malaise is also common. These The diagnosis can be confirmed by low ascorbic acid level. Lab evaluation also revealed anemia due to blood loss within the tissues, normocytic or associated iron deficiency anemia microcytic, the latter of which occurs in part because vitamin C normally enhances iron absorption in the in the small intestine. Okay, yes. In seeing any bone pain, petechiae, anemia, maybe the bone pain, petechiae, anemia, maybe the sign of leukemia. Includes an LDH level marker of cell turnover and bone marrow biopsy. However, the pain is due to bone marrow infiltration, would cause multiple cytopenia, not isolated anemia. Petechiae is caused by thrombocytopenia, not seen here. Moreover, lymphadenopathy and hepatosplenomegaly uh, are typical and absent in this case. And arthritis and anemia may be the symptoms of IBD, but the diagnosis is less likely. The patient GI symptoms, diarrhea, abdominal pain. When the findings can oral ulcer, not gingivitis, subcutaneous nodule, erythema nodosum, rather than petechiae. Yes. Platelet is normal, this patient. High creatinine waiting for transplantation. Waiting for transplantation list. PTT is like low. So yes, it's not a problem. Maybe because we have done everything. So platelet dysfunction in CKD. Okay, platelet dysfunction in CKD pathogenesis. Look at the box first. Platelet dysfunction in CKD. Rising urea upregulation of nitric oxide. Rising urea upregulation of the nitric oxide decreased platelet adhesion, activation, and aggregation. Clinical feature there is easy bruising, mucosal bleeding, epistaxis, GI hemorrhage, normal platelet count, normal coagulation studies. Treatment is desmopressin, increase von Willebrand factor secretion from the endothelial cells. Only required if having bleeding symptoms or upcoming procedure. If having bleeding symptoms or upcoming procedure. So this patient should be given desmopressin. Okay. Classic causes of prolonged bleeding. Persistent epistaxis include platelet or coagulation disorder. In this case, this patient has normal platelet count and normal coagulation profile. In addition to CKD, the most likely diagnosis is platelet dysfunction, a common cause of easy bruising and mucosal bleeding, and a common cause of easy bruising and mucosal bleeding in those with CKD patient. In patients with CKD and bleeding tendencies, a diagnosis of platelet dysfunction can be established from a normal platelet count and normal coagulation studies. Symptomatic patients are typically treated with desmopressin, which stimulate the release of von Willebrand factor and reduce bleeding time. Uh, factor 7. Factor 7 is extrinsic. All, always remember 12, 11, 9, 8, 12, 11, 9, 8, and everyone has to be the perfect 10, 10, and the 7 in the so 12, 11, 12, 11, 9, 8, these are the intrinsic and 7 is the extrinsic, and the common pathway is the factor 10. And for intrinsic, you need to do the for intrinsic PTT, and for extrinsic PT is the determiner. Like you can find the intrinsic pathway problem by PTT, and you can find the extrinsic problem like PT. I don't know you will understand or not. This is from Pathoma. Yes. Yes. Yes, it is here. Look, there is no central pallor. It is all red. So hereditary spherocytosis is one classic feature. Like MCHC is higher in hereditary spherocytosis, and nobody has these MCHCs higher. Okay, this patient is anemic, has spherocytes, small round hyperchromic red blood cell without central pallor on peripheral smear, which are indicative of hereditary spherocytosis. Hereditary spherocytosis is usually an autosomal dominant disorder and a common in Northern Europe. A defect in RBC membrane protein spectrin ankyrin results in spherocytes that are less deformable than normal biconcave RBCs and are more prone to splenic sequestration. Depending on the extent of the hemolysis, patients have classic triad of hemolytic anemia, jaundice, splenomegaly, generally seen with severe hemolysis. Pigmented stone can develop from excess bilirubin, cause right upper quadrant pain as seen in this patient. Lab studies usually show elevated MCHC due to membrane loss and RBC dehydration. Other findings include reticulocytosis normal to elevated, red cell distribution wide due to various RBC forms, reticulocytosis, spherocytosis, normal RBC, and MC low to normal MCV volume. Low to normal MCV volume. Diagnosis is clinical but may be confirmed with specific tests, osmotic fragility test, using 5-melamine binding test. Treatment is generally supportive. Folic acid transfusion, folic acid transfusion, folic acid transfusion for severe anemia. In severe case, splenectomy may be considered to improve the anemia and reduce gallstone risk. Okay, sorry. I'm coming within 5 minutes. Five. Yes. low. Looks like, but he's a picky eater. He's there, and the house, uh, 2008. Okay, oh, it's a distractor. Before 1950, then led, uh, maybe the cause. Before 1950, isn't it? House Bill 2008 is there is no lead. Looks like maybe. Okay. Okay, iron deficiency is common in nutritional deficiency in children and infants. Iron store are affected by the maternal iron stores, prenatal or perinatal hemorrhage, and the and the gestational age of the infant at delivery. Also, prematurity is a risk factor for iron deficiency. Term infant usually have adequate iron store. Term infant usually have adequate iron store for the past 6 months of life. After 6 months, inadequate dietary intake becomes the most important cause of inadequate iron intake becomes the most important cause of iron deficiency. Early introduction of excessive intake of cow's milk is problematic as cow's milk has low iron content and bioavailability can cause occult intestinal blood loss in infant. Children should not be started on cow's milk until age 1 year, and children more than 1 year should consume less than 24 ounce per day. Consumption of more than 24 ounce, like 700 ml per day, is a risk factor. So more than 700 ml per day is a risk factor for iron deficiency. A typical glass content 8 ounce. Okay, a typical glass contains. Okay, more than 3 glass of drinking milk could be harmful. Okay, it may cause iron deficiency. Okay, children with iron deficiency are often asymptomatic and telltale may not have telltale syndrome such as pica, fatigue, or pallor. Therefore, universal screening is recommended by age 1 year. The diagnosis is typically based on a complete blood count, typically showing low hemoglobin, low MCV, and elevated red cell distribution with the reticulocyte count is classically low because the bone marrow with iron deficiency cannot increase the reticulocyte count production, although low, less than 2% reticulocyte index, reticulocyte count into hematocrit divided by normal hematocrit is a better indicator of hypoproliferative anemia. A peripheral smear would be expected to show microcytic hypochromic erythrocyte, although it is usually not needed in the initial workup. Further testing iron studies is not necessary in children with the classic presentation. The most cost-effective approach to treatment is empiric iron therapy. The most cost-effective approach to treatment is empiric iron therapy. Hemoglobin should be rechecked in 4 weeks if the hemoglobin has risen 1 gram per dl. The oral iron therapy should be continued for 2 to 3 months after hemoglobin normalized to replete iron stores. Okay, box. Iron deficiency anemia in young children, prematurity, late exposure, age less than 1, delayed introduction of the solid exclusive breastfeeding after 6 months, cows, soy or goat milk, and age more than 1, more than 700 ml per day of cow's milk, and less than 3 servings day of iron rich food. Screening hemoglobin at age 1 and hemoglobin less than 11 gram per del, and decrease MCV and increase RDW. Empiric trial of iron supplementation. Okay, his PTT patient is on, patient is on low molecular weight heparin. Yes, yes, he is. The patient is started anticoagulant therapy. After anticoagulation therapy, this platelet count low, so it is heparin induced thrombocytopenia. So you should give unfractionized heparin. No, now which of the following drugs sorry was most likely used? Sorry, so it may be enoxaparin. Unfractionized should be given now, isn't it? Like it is clear. Low heparin induced thrombocytopenia, and our preferable is low molecular weight heparin. It is very easy to use. Oh, you are right. Okay, this patient markedly elevated APTT is suggestive of unfractionized heparin use. This presentation is new onset thrombocytopenia and arterial thrombosis in the setting of heparin use is due to heparin-induced thrombocytopenia. Type 2 heat differ in onset, clinical course, and severity of the disease. Okay. Why? Acha, okay, first we read the enoxaparin one. Enoxaparin typically does not prolong the activated PTT. It may, in rare cases, causes mild prolongation. However, the risk of heat is lower with enoxaparin than with unfractionized heparin therapy. Okay, that's why the risk of heat is lower in enoxaparin. Okay, I am reading. Oh, okay. Okay, type 1 heat. Type 1 heat occurs due to non-immune direct effect of the heparin or platelet activation, and usually presents with first 2 days of heparin exposure. The platelet count then normalizes with continued heparin therapy, and there are no clinical consequences. And type 2 heat is more serious immune mediated disorder. Type 2 heat is immune mediated disorder due to antibodies to platelet factor 4 PF4 complex with heparin. This leads to platelet aggregation, thrombocytopenia, and thrombosis. These lead to platelet aggregation, thrombocytopenia, and thrombosis. Platelet count usually drops more than 50% from baseline with a nadir 30,000 to 60,000. Type 2 heat usually presents 5 to 10 days after the initiation of the heparin therapy and may lead to life-threatening consequences, limb ischemia and stroke. Okay, why so is it thrombin is the main culprit? No, three. From uh, hmm, tissue thromboplast tissue, thrombin is what? Factor 2 or 1? Tissue thromboplastin is okay. Okay. Enoxaparin only factor 10A and thrombin is factor 10A and 2. 2 and 10. Unfractionalized, yes. Oh, what affects what? Yes, it does. Enoxaparin, though they have remember in this way like heparin and warfarin. How will you monitor the heparin? You will monitor the heparin by PTT, and you will monitor the warfarin by uh, PT. So some sort of PTT is raised, but not that high. like unfractionized heparin. It is massively high, but if you want to monitor like heparin, you need to see the PTT. Another difference in between unfractionized heparin and enoxaparin is like high PTT in unfractionized heparin. Then in enoxaparin there is slightly low PTT. Okay. Reticulocyte count is higher, platelet is low. Is it anemia? There is anemia, there is thrombocytopenia, and there is kidney problem. He has fever and neurological deficit? It is TTP. He is acting strangely. So there are 5 features we have found: neurological deficit, fever, anemia, thrombocytopenia, and acute kidney injury. So it's TTP, thrombotic thrombocytopenic purpura. So in thrombotic thrombocytopenic purpura, DIC-TTP has help in 4. We will found in peripheral blood film like helmet cell, fragmented cell, schistocytes. Okay, okay, it's TTP, thrombotic thrombocytopenic purpura. In thrombotic thrombocytopenic purpura, decrease atom TS13, uncleaved von Willebrand factor multimer, platelet trapping and activation, acquired or hereditary. Hemolytic anemia, increase LDH, decrease heptoglobulin, increase LDH, decrease heptoglobulin with schistocyte, and there is thrombocytopenia, increase bleeding time with normal TTP, and sometimes renal failure, neurological manifestation, and fever. Management is plasma exchange, glucocorticoid, rituximab, and caplacizumab. Caplacizumab. Thrombotic thrombocytopenic purpura is marked by small vessel thrombi that consume platelet, shear red blood cell, and cause organ damage, primarily renal and CNS. This patient has several manifestations of classic TTP centered thrombocytopenia, MAHA, renal insufficiency, neurological changes, fever not usually present. TTP is usually due to acquired autoantibody to ADAMTS13, a protease that cleaves one relevant factor on the endothelial cell. As ADAMTS13 level As ADAMTS13 levels fall due to antibody one relevant factor multimer accumulation of the endothelial wall traps platelet at areas at high shearing force, small arterial capillaries leading to thrombus formation. Most cases arise in the middle age, are idiopathic. However, chronic infection, HIV, malignancy, and certain medications can increase the risk of TTP. Diagnosis is based on clinical and lab data. Thrombocytopenia, platelet count decrease, 30,000 MAHA, increased levels of indirect bilirubin, AST, alanine aminotransferase, LDH, and reticulocyte count should also raise suspicion. A peripheral blood smear showing intravascular hemolysis, schistocyte helmet cell, and schistocyte helmet cell triangle cell supports the diagnosis. TTP must be treated urgently with plasma exchange. Patients should Patients should also receive high-dose glucocorticoid rituximab to suppress autoantibody production by B cell. Caplacizumab, monoclonal antibody that blocks von Willebrand factor binding site for ADAMTS13 autoantibody, is frequently added for severe disease. Okay. Is it like G6PD deficiencies? After giving amoxicillin cannot cause mild splenomegaly. It can cause other problem. Mm, There is anemia, thrombocytopenia, not thrombocytopenia, but there is anemia, splenomegaly, sclerotic tears. or it is other disease. What is it? Other sickle? What may be our differential? Is it G6PD or it is PNH? Okay, it's a drug-induced hemolytic. It's hemolytic anemia. It is normocytic normochromic. This patient's MCB is normal. MCHC is normal. Okay, it's a drug-induced immune hemolytic anemia, drug-induced immune mediated hemolytic anemia. So this patient received amoxicillin and subsequently developed symptomatic anemia. This patient received amoxicillin and subsequently developed symptomatic anemia, fatigue, exertional dyspnea, splenomegaly, and jaundice. Raises strong suspicion of drug-induced hemolytic anemia. Penicillin, amoxicillin, and cephalosporin. Penicillin and cephalosporin common triggers of drug-induced hemolytic anemia. These medications bind to the surface of the erythrocyte, creating an hepton for IgG attachment. IgG code for IgG attachment, IgG coated erythrocytes are partially or wholly phagocytes. IgG coated erythrocytes are partially or wholly phagocytes by the splenic macrophage, leading to extravascular hemolysis. Complement mediated intravascular hemolysis may also occur. These patients have signs of anemia, fatigue, pallor, dyspnea, hemolysis, dark urine, jaundice within 2 days of the medication exposure. Jaundice, dark urine within 2 days of the medication exposure. Lab mm, lab assessment typically reveals indirect hyperbilirubinemia, elevated lactase, indirect hyperbilirubinemia, elevated lactate dehydrogenase, decreased heptoglobulin reticulocytosis. Most patients have normocytic anemia with a normal or slightly elevated MCV due to presence of reticulocytosis. Splenomegaly can also occur due to increased red blood cell sequestration in the spleen. The diagnosis is made by Coombs positive, which identifies IgG or C3 complement fragment attached to the erythrocyte surface. Because penicillin and cephalosporin induce hemolysis primarily triggered by drug binding to the erythrocyte surface, withdrawal of the medication generally leads to resolution. Therefore, amoxicillin should be discontinued in this patient. A different class of antibiotic should be started. Okay, next. Why parvo? Platelet count is normal. Parvovirus B19 causes asplenia. Like, uh, sorry. Parvovirus B19 causes aplastic crisis, aplastic anemia. Aplastic causes all the count is low, like hemoglobin platelet. Yes, maybe. Okay, this patient with sickle cell anemia, this patient with sickle cell anemia, this patient with sickle cell anemia has symptom. This patient with sickle cell disease has symptomatic anemia and indirect hyperbilirubinemia, low-grade fever days after receiving blood transfusion. These findings are concerning for delayed hemolytic transfusion reaction. Delayed hemolytic transfusion reaction occurs in patients who have previously exposed to foreign RBC antigen prior transfusion pregnancy. This antigen is minor, non-ABO, and typically causes low, often undetectable antibody response after initial exposure alloimmunization, similar to that seen in rhesus negative primary carabita with rhesus positive fetus. However, on subsequent exposure via repeat transfusion, an anamnestic antibody response occurs in which memory B cell rapidly produce more antibodies. These antibodies bind to donor RBC, causing extracellular hemolysis. Sickle cell disease. Sickle cell disease patients are high delayed hemolytic transfusion reaction due to frequent exposure to minor antigen via repeated transfusion. Once onset of delayed hemolytic transfusion reaction is more than 24 hours up to a month after transfusion. Most patients are asymptomatic. However, sickle cell patients are more likely to have symptomatic severe anemia due to sickle cell related intravascular hemolysis in addition to delayed hemolytic transfusion reaction related extravascular hemolysis. Symptomatic delayed hemolytic transfusion reaction causes fatigue, dyspnea, jaundice, low-grade fever with lab evidence of hemolysis, including elevated indirect bilirubin LDH, reticulocyte count, as well as decreased heptoglobin. Because these results may be present at baseline in sickle cell disease patients, a new positive direct antiglobulin test is important for diagnosing delayed hemolytic transfusion reaction. Management is supportive. Prevention include review of prior antibody screen and use extended antigen cross-matched blood when transfusion is required. Next, If we give fluid, again spleen will kill the uh, RBC, isn't it? Yes, spleen is palpated, and a sickle cell disease patient has splenomegaly. So that means the RBC is trapping over the spleen, and that's why there is splenomegaly, isn't it? Yes, I want to cut the spleen. Okay, may not be the answer. Sab, maybe 9. I don't know. I don't know. Remember. Okay, I was in the at. Okay, I am taking too far. Okay. Okay, first splenectomy, the wrong one. The recurrence rate of splenic sequestration is high and may warrant splenectomy a definitive management. However, splenectomy is not typically performed in the acute setting, is often unnecessary due to natural history of splenic autoinfarction in patients with sickle cell. Okay, okay, cannot be done in acute setting, and there is a natural history of splenic autoinfarction in patients with SCD. So we do not need to kill the spleen. Remove this. Yes, yes. Okay, this patient with sickle cell disease has relatively acute onset fatigue, lethargy, along with splenomegaly, abdominal pain, and signs of anemia, low hemoglobin, tachycardia, flow murmur. These findings are concerning for acute splenic sequestration crisis, a life-threatening complication of sickle cell disease in which RBC become entrapped within the spleen. Splenic sequestration presents in early childhood before the spleen becomes fibrotic from repeated infarction. A large volume of blood pools in the spleen, causing splenomegaly, an acute drop in hemoglobin. The presentation include fatigue, lethargy, pallor, which can quickly progress to hypotension and hypovolemic shock. Because cardiac output increase to compensate for decreased RBC, oxygen carrying capacity, tachycardia, and a systolic flow murmur are common in addition to anemia. Lab findings include thrombocytopenia due to splenic trapping of the platelet and reticulocytosis. Bone marrow respond to decreased RBC. In management of acute splenic sequestration crisis IV resuscitation with IV isotonic fluid. A packed cell transfusion is also indicated to help store circulatory volume and correct the anemia. However, the transfusion should be administered cautiously. Transfusion should be administered cautiously, half of the normal volume, because RBC in the spleen may return in circulation, resulting in rapid increase in hemoglobin and complication causing hyperviscosity syndrome. It is heat. Heparin-induced thrombocytopenia, isn't it? Oh, stop. Direct thrombin inhibitor by Velorudin. They are bad. By Velorudin, argatroban, and dabigatran. Mnemonic is bad. Okay. Are bad. By Velorudin, argatroban, and dabigatran. These are the direct thrombin inhibitors. Dabigatran and serotonin release assay is the gold standard. Look at the heparin-induced thrombocytopenia. Okay, I am reading the clinical feature of the HEAT. Suspected with heparin exposure more than 5 days of any of the following: platelet count reduction more than 50%, platelet count reduction more than 50% from the baseline, arterial or venous thrombosis, necrotic skin infections, necrotic skin lesions at heparin injection site, and acute systemic anaphylactoid reactions after heparin. Diagnostic testing: serotonin release assay, gold standard. Confirmatory tests: start treatment in suspected case prior to confirmatory tests. Therapy: stop all heparin products. Start a direct thrombin inhibitor, argatroban or fondaparinux. Type 2 heparin-induced thrombocytopenia, a life-threatening complication of heparin therapy. A drop more than 50% and a new thrombus within 5 to 10 days of initiating heparin should raise suspicion of heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia may manifest sooner in patients with previously exposed heparin. Heparin-induced heat is an antibody mediated and causes a mild to moderate thrombocytopenia, rarely less than 20,000, with minimal uh, bleeding risk. However, venous and arterial thrombotic risk is significant, as high as 50% in untreated heat. If heat is suspected, all heparin products, including heparin flashes, should be discontinued immediately, and anticoagulation should be initiated, and non-heparin medication, argatroban, dabigatran, should be given. Okay. Yes.